Our next speaker, I just want to, and I'll just go through the schedule a little bit. Our next speaker is going to be Pascal Fuchshuber, is going to talk to us about radiofrequency ablation and also microwave for ablation. We are then going to ask the first segment speakers to all come up so that we can go through some of your questions and have audience questions as well. There's some really excellent questions there. And we're then going to let you have a break to stretch, and then we hope you come back after that as well. We're going to talk about fires, interactions with cardiac devices, which most of us really don't understand very well. And then I'm going to tell you how you can participate in the validation of this whole program and really help SAGES to do that. So I hope you'll stay around, and Pascal is going to talk to us about RFA.
Thank you, Leanne. And again, you can message us at 22333 for those that came late, and tweet at Paul, P-O-L-L, Fuse. Thank you very much. I'm going to be brief because this is really getting very esoteric now, and I'm going to basically go over some of the things that you've heard already, but I'm going to introduce the concept of microwave energy. So I have nothing to disclose. So this is really the fundamental thing. So we talked about thousands, 100,000s, millions. How about 1,000 billion? Because that's what the hertz is that we use with microwave. And just to give you an idea of what the spread here is, when we use RFA, we use what we're talking about, which is electromagnetic effect from electrosurgical energy in the radio frequency, which is 0.5 megahertz, and the wavelength is about 100 meters. So imagine that when you fire your, excuse me, Malcolm, Bovie stick or electrosurgical monopolar instruments, the length of the wave is 100 meters. When you fire a microwave, the length of the wave is less than 10 centimeters, and you are at about 1,000 billion hertz, okay? So what happens on RFA is what Malcolm already talked about, and I'm just going to briefly touch about it. It's alternating current going through the tissue or being applied to the tissue, and the tissue responds with ionic agitation and then friction and heat, and the heat travels around to the tissue and does its effect. When you fire up a microwave, you basically have what we call a dielectric effect or dielectric heating, where the water molecules, bipolar molecules, start dancing around in the electromagnetic field that is created by the microwave frequency. And so they go at 1 gigahertz back and forth. What happens? The same thing. You get heat. Okay, that's how it works with microwave. Problem is, the difference is here, and I'm going to come back to that, is that there's no boundaries for that microwave energy. It is not related to, you know, how many ions are in the tissue. All the tissue that we work with has water, and everywhere where there's water, there's going to be heat or energy. So there's going to be energy in the vessels, outside the vessels, and in the vessel wall. I'll come back to that. So again, the deposition of energy is what makes the difference here between all these things. And the essential difference between ablation of tissue and electrosurgical effect from a monopolar instrument is that there is no impedance control on your monopolar instrument. So there's a rapid rise of impedance that limits the depth of where the thermal energy travels, and that everybody can visualize that by when you stick the active electrode of a monopolar instrument into the liver and you start firing it, you'll get a very small zone of destruction. And the kicker with radiofrequency energy for ablation is that the design of the active electrode is such that there is slow deposition of energy over time, and the algorithm by which the energy is applied into this active electrode is such that there's slow deposition, and therefore we overcome the impedance by keeping the desiccation as low as possible for as long as possible so that we get a bigger volume. And that's a little bit of a trick with the old energy that we've been talking since this morning, since this afternoon 1:30. With microwave energy, we are not really into the impedance issue. We just apply the very high frequency field of electromagnetic energy, and wherever there's water, there's heating in that field. And when that field gets very hot, of course, there's also thermal spread on top of that. So in RF ablation, you start with frictional heating of the ions. That's this grayish zone. And these are this is schematic, 4 little active electrodes from the antenna. And over time, there's additional conductive heating from the tissue that gets heated up by the frictional heating. So you have a rise of impedance that reduces the ability to conduct current, and you apply a continuous low voltage output around 60 volts to keep that process slow over time to prevent rapid tissue heating and desiccation that would otherwise stop the process. So you draw the process out as much as you can with this technique. Best example I can think of is you want to cook chicken on the barbecue or you want to cook steak medium rare. If you use the concept of the monopolar instrument, it's medium rare. You get charring and you get impedance and the heat doesn't get into the center. With this technique, you want to cook chicken. That means you want to make sure the heat goes all the way through. The biggest volume possible gets heated. Now, the difference between radiofrequency ablation and microwave ablation, as I already alluded to, is that microwave ablation doesn't respect boundaries as much as RFA does. What does that mean in reality? In reality, it means that when you apply radiofrequency energy, the energy will stop at certain boundaries, which is the blood vessel in this case. The conducted energy, as well as the convected heat energy that comes from this heated conducted center. In microwave energy, that primary energy that's applied, the electric magnetic field, does not stop at these boundaries, and this vessel will be destroyed by thermal energy. The convected energy that comes from the heat of the primary field will get bounced off certain structures. So there's a real fundamental difference between those two in terms of when you apply them in clinical practice. And I don't think that we're going there, and I'll show you that, but that's not really what I want you to take home in terms of clinical practice. What I want you to take home is that there are physical differences between the two when you use them. So here's an example of radiofrequency ablation zone. This is a pig liver, and you can see that the energy gets deflected around boundaries, in this case, large vessels. Whereas when you use microwave energy, this is also a experimental pig liver, there is no bouncing around vessels. They all get included. And this is another schematic representation of what we call the thermal sink when we use radiofrequency ablation, which is nicely depicted here with this vessel deflecting the convected energy. And microwave is not affected as much by that. Again, when we compare those two systems, as we said before, radiofrequency ablation is a closed circuit system with an active electrode and a dispersive electrode, and there are some implications because we'll use a lot of energy compared to, let's say, a simple monopolar instrument. Microwave is an antenna system. There is no circuit. It's open, and therefore there is no dispersive electrode. So when we use radiofrequency ablation, we need to be very cognizant about the fact that we have a lot of energy going through this circuit. 250 watts. So you're putting up, you can't do that with a monopolar instrument active electrode. You can go to about 100. We are going to 250 because we want to ablate large volumes. So the systems that are currently in use have more than one dispersive electrode, but because what happens if we only used one, even this large area would be too small to disperse the energy, and we would get heating and skin injury. But even if you use 2 or 3, you have to be cognizant about the fact that you can cause injury if you change the orientation or you apply these suboptimally to the patient. So it's very critical that you use good technique in application of these pads or dispersive electrodes, excuse me, Monroe, and you can actually create skin burns by just leaning on one of these and changing the space configuration of that dispersive electrode such that there is a point of higher density and you get skin injury. Most of the devices on the market, in addition, have a temperature monitor at the skin dispersive electrode interface and will give you an alarm if that temperature goes over a certain threshold. What are the indications for ablation? Very briefly, they're palliative intent for pain in bone lesions or other palliative intents. We use it for unresectable lesions in the liver or in other organs because of either location or tumor burden or because the patients are a poor candidate for resection. And in liver disease, we use it as a bridge to transplant. So what are some of the indications here? Real quick, this is a lesion that's situated at the confluence of all 3 major hepatic veins, clearly not resectable, but it's controllable with radiofrequency ablation. Again, because there are these boundaries, we can actually use the boundaries to our advantage when we ablate lesions that are very close to large vessels. We use radiofrequency ablation. If we used microwave ablation, we would be in trouble because we would probably be at least at risk of thrombosing some of these veins. And this patient had a long-term outcome. This was a couple of years after ablation. These are typical patients with neuroendocrine metastases. We all know that if we reduce the volume by 80%, we get good palliative results. This is a perfect patient where we would do ablations. Now I'm going to briefly touch on unintended injuries. We talked about those already, but if you ablate close to the surface of the liver, you can get thermal spread into other organs or diaphragmatic surfaces, stomach, gallbladder, small bowel and large bowel. If you ablate close to large vessels, you get bile duct or vascular injuries. Larger lesions greater than 5 centimeters, usually you get very high recurrence rate because of incomplete ablations. And then again, if you do multiple ablations, clearly you are not destroying all the tissue. And then we talked about skin burns as one of the ways the operator can injure the patient. So skin burns in microwave ablation can be an issue, especially if you put the electrodes very close together. This is an example where a 3rd-degree burn occurred and actually a skin incision had to be done. Hepatic abscesses can occur where there's large coagulation zones that get infected. This is an example of a bleeding complication after ablation where a large vessel was injured and then led to a hematoma that was significant enough that it required transarterial embolization. There are vascular injuries with necrosis of portions of the liver in this case, or arteriovenous injuries with large life-threatening hematomas that can occur. Biliary strictures can occur, and biomas can occur. So these are all injuries related to the ablation, and with that, I thank you very much for your attention. Okay, you're going to sit down?